to know you a little bit better than some other people because I follow you about once a month, and you are my mentor. But for those people who don't know you, if you wouldn't mind just giving a brief introduction about who you are, where you come from, what you do, that sort of thing.
Yeah. So I am a neurologist by training. I am fellowship trained in movement disorders and in sleep disorders. And I'm currently here in UT San Antonio, Division Chief of Movement Disorders and Division. And happy to be seeing patients with movement disorders, with Parkinson's disease, also with sleep disorders. And super happy to be involved in medical student training, just as yourself, and have been doing that for quite some time.
And we are lucky to have you as a mentor. You're very um, astute and shrewd, and you always provide valuable insights. I think it's we go from like classroom learning to actually seeing things in real life. And even though we haven't really covered the neurology section of things yet, I think it's been very interesting to see how you are putting into practice the things that we've been learning, like the elementary stuff, and then you add on top of it the more gestalt things that you can't really get from a textbook in terms of like putting together all the puzzle pieces of what you're seeing from a patient and kind of deducing conclusions and stuff. So we're very fortunate to have you here at UTL San Antonio, and I was hoping you could tell me a little bit more about your medical training. It's my understanding you trained overseas, I believe in Hungary, is
Mm-hmm.
that right?
That is correct. Well, thank you, first of all, for having me. This is a great honor to be interviewed by you. So, I was born in Greece, in Athens, Greece, and that's where I grew up. And did my medical school training, which is 6 years in Europe, in Budapest, Hungary, and then went back to Greece and started my residency in neurology, which I always wanted to be a neurologist. So, while starting there, I had envisioned that I wanted to do something at a larger scale and be involved more with, have more research and kind of go where things happen. So that's when I decided I wanted to be either, I didn't know which continent I will be in, Europe or the US, but eventually, after spending a few months in the UK, I decided I wanted to cross the pond and go to the US. So I started my USMLE studying and tests and all that and the steps. And then I landed in New York where I did my residency, my neurology residency. And then after that, moved over to Boston and I completed my two fellowships. And so, yes, a little bit of, I like to call myself a citizen of the world. So that was the training at that point, and then I moved to Minneapolis for a few years, 5 years, and then back to Boston, and now I'm here.
So globe trotting all over the place.
You bet.
So, can you tell me a little bit more about what medical training was like in Hungary in your undergraduate medical education, and how did you end up in Hungary? Is it common for people in Europe who maybe they're born in one country but they end up doing medical school in a different country?
It is. It is actually. It is quite common because we're part of the commu- European community. There's no borders per se, so we are everything is quite easy access. So you can go anywhere you want. That particular program is an English speaking program, so and it's a very good school. So I happened to go there, and it's very different than what you're used to here in the US. The system is different because it's 6 years. There's no college, it's just medical school. You go out right after high school, you start medical school. And it is, well, of course, that was a few years ago, so it's not that I just graduated. So things were taught very differently. Of course, the content curriculum is the same, but the testing, for example, and finals were verbal. So there's a lot of, anxiety and having the professor right across you and opposite, like grilling you and asking you all these questions. But that prepared me for real life. You have the patient right in front of you, and they ask you questions, or they can be intimidating at times. So I think that was a good lesson in that sense. And teaching was a little bit more older school, the way that it was traditionally done. Obviously, coming here and getting involved in education, in medical education here in the US, I really love how it has evolved into more, I want to say, student friendly methods that you're not a passive learner, you're more of an active learner. And that's how we all learn, or at least most of us learn, where we're actually applying what we have been taught, but in real time while we've been being taught. So what you just referenced, like putting what you have been taught in the first couple of years into context where you come in clinic and you see patients with me. That's why I'd like to point out, hey, watch this. This is how it is, and this is that what you've learned. This is how it applies here. So these are some of the things that, yes, books cannot teach you, and you have to do it and experience it and apply it by yourself.
Awesome. Thanks for spelling that out a little bit for us. And if you wouldn't mind going a little bit more now into neurology, and like how soon after in those 6 years do you have to kind of come up with your decision of, okay, I'm going to be a neurologist or internal medicine or surgeon or whatever it is. How soon into your undergraduate medical education did you make that decision, or was it like incumbent on you to make that decision?
So first of all, there is no particular time that you need to make a decision. Of course, you need to make it as soon as, as late as the deadlines, but as soon as you feel you know what you want. In my particular situation, it was the last clerkship that I was in, and I had no other, I was reaching my deadline where I had to decide. The problem with not being able to decide was that I liked many things. So I liked OBGYN, I liked internal medicine, and then I went into neurology, and I basically fell in love with neurology. And it was very different than just liking the others. I just craved to wake up in the morning and go and see patients with neurological disorders. So I said, this is it. That's for me. And I got a little bit of a pushback from colleagues or from mentors at the time, because neurology did not have, and we're talking about 15 to 20 years ago. I'm dating myself, but neurology is very different now than what it was. And it was more like diagnose and IDOs. It's just this is what you have. Good luck. So things have changed immensely, and I could see that back then, that there were a lot of frontiers to break, and a lot of discoveries to make, drug discoveries and therapies and new therapies, new understanding, because we did not really understand the mind, the brain. We still don't, but we are better positioned now than we were 20 years ago. So I said, nope, this is why I want to go into neurology, to contribute to this advancements that have been happening over the past 10, 15 years.
And I imagine, like you were saying, there's a lot of pushback that you experienced. Do you think that a lot of that was because of your sex, your gender as a female? It wasn't very common, or it was just sort of because the field of neurology itself was still very new and they were still figuring things out?
Right. Yeah. No, it wasn't gender driven. The pushback I had is because of neurology. Like, you will be bored, you will be seeing headaches the whole time, and that's all you're going to treat and nothing else. And basically, you're not going to treat anything else. You're not going to treat anything. So it was not gender based, but more rather than context based or specialty based. And of course, the people who told me about this were not neurologists. So
that brings me to another interesting question, sort of on that subject. You were saying that back then, obviously not too long ago, but back when you were still starting out in neurology, things were kind of maybe viewed by patients or clinicians as almost futile, like you said, diagnose and adios. But now there are a lot of, so a lot of people would say miraculous interventions and therapeutics, and we'll get into that more detailed now. I think one of them is what your specialty is in movement disorders and deep brain stimulation. But on that topic of like innovation and stuff, where do you see the field of neurology going from here, especially given that your specialty is in movement disorders? Do have we reached a sort of like end of the road in terms of DBS is kind of like as good as it gets, or where do you see neurology and movement disorder treatments going from here?
So these are not two different things, but it's a wide kind of spectrum. Neurology has not reached the end of the road. It's actually just beginning. We're just paving the road to innovation, to new therapeutics, and it's very exciting. Look at what's happening at dementia, right? We're now starting to talk about perhaps, we can treat dementia, or if not treat, at least slow down to a certain extent. Now we're discovering more about the value of sleep in brain health. We're discovering the value of exercise in brain health, all these things. We're talking about prevention. And once we do have the disease, whether it's neurodegenerative disease, whether it's dementia, whether it's Parkinson's disease, we do now are discovering more therapeutics to be able to not cure. We're not talking about a cure yet, but we're certainly talking about treatment that improves the patient's quality of life. And in more specifically, deep brain stimulation has been around since 2002, so it's not a new therapy. However, the advancements and the upgrades that these devices have gathered throughout the years are mind-boggling. We're now able to use AI better, machine learning, to be able to identify the symptoms of the patients and then deliver therapy accordingly. So instead of doing it manually, it's been done through machine learning. So add that to the mix. Now things are accelerating and, of course, becoming more efficient. And we're treating more and more disorders in neurology and in movement disorders as well.
So do you think that a lot of the innovations that are to come in movement disorder therapeutics is centered around DBS, or do you think that there's something else that may lie on the horizon, or is it just a matter of like ameliorating what we already have with DBS?
DBS is part of it. So there's different lines of therapeutics or discovery. There's neuromodulation, there's neuroprotection. So like I said, prevention. There's also, and in particular in Parkinson's disease, looking at new mechanisms of action of medications, and also going back and recognizing that Parkinson's, for example, doesn't start when we see the tremor. It starts many years before that. So the whole pathophysiology starts before that. We have markers. Biomarkers are starting to merge in different neurological disorders. And once we have biomarkers, then we can detect the disease earlier so that we can intervene earlier. And by intervention, we can delay the manifestation of the disease and delay the progression of the disease. So it's not just deep brain stimulation. There's a lot of other things.
Okay, so on the topic of movement disorders, I kind of want to go back a little bit in time and understand how you decided to specialize in movement disorders. Was it a particular encounter, or what clicked for you that you said, this is what I want to be a super specialist in?
That's a good question. Things obviously matured and came later as I started treating patients. But in neurology, I decided I wanted to go into movement disorders because there's so many things you can do, and you can contribute to the patient's life significantly. You see the patients very frequently. You become part of the family. You can make a difference. You can make a difference to their lives and the quality of lives, to the lives of their spouses, to their children, to their grandchildren. Now they can, with your intervention, therapeutic intervention, they can go on a cruise, they can travel with their grandchildren, they can go to a graduation, things that they couldn't before.
Mm.
And this is really gratifying.
Do you think that movement disorder, the subspecialty of movement disorders and sleep disorders in neurology is unique or kind of different than the other subspecialties in neurology where you have that ability to really make a big improvement in people's lives?
It's one of them. I wouldn't say it's unique. We also have epilepsy. So epilepsy, for you have patients who have seizures, and then with all the medications that have come through, and then last 20 years, we really make a difference and control the seizures on the most part. So that improves quality of life. In terms of sleep, which I kind of also include a little bit in neurology, we have so many patients with narcolepsy. So young patients who can't function because they're constantly tired or have sleep attacks, and then new medications are coming out to treat this so that the patients can go to college, finish college, hold a career, hold a job, things that they couldn't before. And it's also about raising awareness. So there's certain diseases that go undetected or end up being diagnosed much later because there's no awareness, or they may not end up in the right specialist, and that takes time to treat, because if it takes time to diagnose, it takes time to treat. Other things in the neuromuscular world as well, we're starting to see more therapies in ALS, for example. Again, I mentioned dementia before. So every single subspecialty of neurology is definitely seeing a growth, and both in therapeutics and in the disease, in disease state, like learning about the disease state much more.
I'm curious to go back to the topic of the difference in medical education and even the practice of medicine in Europe and in America. I imagine you still have some connections with clinicians and doctors over there. How do you view the practice of movement disorder medicine different in Europe versus in America?
Well, yeah, and that differs, and it depends on the country, but I think that the patients may not have, not the patients, the people around them, there might not be so much advocacy for the disease. We may not see so much support from not their peers in the family, because there's a strong family component in the Europeans, but mostly from the healthcare profession, like social workers and PTOT and all these services they don't have large centers. Some there are, but they're not as frequently seen to have like a Parkinson's center, or even more than 2 or 3 Parkinson's centers in a city. So you don't have that access to a Parkinson's center or multidisciplinary Parkinson's center or movement center in Europe as much as you do here. It's just like by comparisons. They do have them, but they're not readily available in every town or every smaller town, so to speak.
Interesting. So do you feel like I think a lot of people, maybe foreigners or people who don't live in America, even people who are American, they have a lot of negative things or views of the American healthcare system and how it puts certain people at disadvantages and stuff. Do you feel like that has ever come into play with the patients that you see, or in your experience in practicing medicine, in terms of somebody who really needs DBS or who needs some crucial intervention that you can provide for them, just isn't able to get it because of insurance or issues like that?
Very rarely, but I have seen it, yes. And mostly in the underserved or non-insured patients. Yes, that is a concern. That's something you don't necessarily have in Europe because it's a socialized medicine. So everyone gets the same care. So yes, there are discrepancies, there are disparities, and mostly in the underserved populations, we do see that, where they don't get the care equal care, there's no equity as much as you would find in other countries.
Mm, mm. I'm hoping you can talk a little bit more about your experience here in San Antonio. I know there's a lot of burgeoning, facilities and institutes, and a lot of funding going towards, you know, aging medicine and the neurosciences and that sort of thing. Like, what has your experience been like as a specialist and an expert in those areas? And have you felt like San Antonio has positioned you, well to really take advantage of that?
Absolutely. San Antonio is a fantastic place. First of all, it's a large town with a small town feel.
Hmm.
There aren't much resources for what I do for movement disorders, which is a white canvas. So we can build a lot of things, and we can help the community in so many ways in clinical care, in support, in awareness, raising awareness, fundraising, things like that. So it is really remarkable. And also, people are fantastic, and they're all willing to contribute to this bigger, larger picture. And our institution, UT Health, is also behind that mission as well. We want to serve as many as we can within San Antonio and also in the periphery. We're talking about South and also West. This is something that we're all striving for because,
Mm.
like I said before, comparing Europe to here, we're at a place in the country where we don't have enough resources. We don't have these Parkinson centers. We are a Parkinson center here, but that's just us. There isn't. The next one is in Dallas and in Houston. So you can imagine that we need to grow and we need to have more centers as well to be able to serve everyone.
Mm. Now, I've noticed a lot of times shadowing you and observing you in the clinic that, you know, medicine in general, but especially what you do is very interdisciplinary, and it relies on the patients, making sure that they're staying active and doing physical therapy and that sort of thing. And of course, with DBS, you work pretty closely, I imagine, with neurosurgeons and people on the university hospital side of things. Could you tell me a little bit more about the interdisciplinary nature of your work and your experience in that, and how maybe that's differed from other places you've been in America? If maybe San Antonio is better at that because of the academic institution that we're at, or I don't know, any sort of comparisons that you can draw.
hmm I think you're right. As a movement specialist, also with deep brain stimulation and other advanced therapies, and as a physician in general, we do collaborate with a lot of other specialties, and that collaboration is key to success for the patient and for the care of the patient. So we do, on a daily basis, collaborate with a social worker and physical therapist, rehab, psychologists, neuropsychologists, psychiatrists, the neurosurgeons, of course, and the families, right? So we should also remember the families and the caregivers, they're all in the mix. So it's a multidisciplinary approach for every single patient. I don't think that it's any different from other places in the US I've worked at. I, I wouldn't say they're more difficult or easier because everyone wants to do a good job. Everyone wants to strive and help the patient in the way they can and their skills allow. So, in that aspect, I think seeing that collaboration is is something that the patients also see and they enjoy. Having said that, of course, there's things that can go wrong, right? Like in any profession, but these are little hiccups that we all encounter, but overcome
Mm,
without major consequences.
mm. Okay, so now imagine you're talking to me. I'm in my third year or fourth year, and I'm telling you, Dr. Val, I'm really considering uh, neurology or something along those lines. What would you say to persuade me, or what sort of argument would you give for somebody to definitely go into your field of specialty? And on the other side of things, what might you say, tell somebody, here, if you're going to go into this, just know that here are some of the disadvantages or the negative sides of things.
Yeah, I've done some research on that. I have also published on the on that topic because I was very interested to see why do students go into neurology and why do they not? Why do they avoid neurology? So a lot of the times it's optics and where you train and who you train with. So first of all, like if you're considering any specialty and you're landed on one, let's say neurology, I would urge the medical students to ask their opinion not from one neurologist but more than one and in different specialties. Now in terms of neurology, I think it's a smart choice. It depends on your personality, it depends on many things. The first decision is whether you want to go into a surgical specialty or a medical specialty. Once you've decided that you don't like surgery or any surgeries, then and you like more medical specialties, neurology is something you've decided on. I would just say that it's a great profession, and I would choose it over and over again. I would not. I've never said or thought that I should have chosen something else. I really don't have anything negative to say, especially with all the excitement of these new innovations that we were talking about. I couldn't have chosen a better specialty for me.
Mm. Mm. Well, that's great. I'm glad to hear that. Let's see what else here. Um, I guess if you can talk to me a little bit more about sleep medicine. We've been talking a lot about movement disorders, but I know you also are a specialist in sleep medicine, and obviously the two have some interplay. But can you tell me a little bit more about what sleep medicine looks like and what promise that field of medicine holds? Does it just come down to like people need to sleep better, or how are interventions and innovations that are coming on in the horizon going to help with that?
Yeah. So sleep is another untapped area that I feel like sleep was where neurology was 20 years ago. So we really don't account for sleep. We don't we don't think not having sleep or being sleep deprived is a big deal. We are a sleep deprived nation by far. We're causing that to ourselves, whether we're working too hard or on our phone too much or whatnot. We don't really consider sleep as important as other functions that our body needs, such as food. So in other words, we don't take sleep seriously, and we should. Because what happens in sleep is something that doesn't happen when we're awake, and that's cleansing or clearing the brain from all the toxin buildup during the day. And long term, this can increase your risk for dementia, it can increase your risk for neurological disorders, neurodegenerative disorders. So people don't realize how important it is. I consider sleep a way of keeping the brain young. So if people would realize that, I think we would have had a different approach, but that's up to us to raise awareness about sleep. And then there's also different sleep disorders. I mentioned narcolepsy. There's obviously the most common one being sleep apnea, but even that, patients, even you tell them that they have to treat it. I understand sometimes the treatment is not very comfortable, but they don't recognize why they need to treat it because they don't, from a night to night basis, they don't realize that they stop breathing at night. And because they don't have that knowledge and it doesn't affect their life short term, they don't feel they need to treat it. It's almost like having high blood pressure. You don't know that you have high blood pressure unless you test it. But it's been ingrained in society that if you have high blood pressure, you need to take pills, and people do so. But with sleep apnea, we're not there yet. People, you tell them they have sleep apnea, you stop breathing at night, it's severe, and they're like, okay, well, I sleep well, I don't need to treat anything. But long term, again, we know it has an effect in in health in general, in heart health and diabetes and brain health. So it needs to be treated. So there's a lot in sleep that we're just learning, and we're just learning what sleep does to our organs if we are sleep deprived. And there's many other sleep disorders, like for insomnia, for example. There's so many misconceptions about insomnia. People think they can take a quick fix by taking a sleep aid, but that's not really what it's all about.
Mm. Now, as people in the healthcare profession, I'm sure you've probably heard a lot about people with burnout and in residency and stuff, people not getting that much sleep, and medical students and stuff. I'm sure you've been through it.
Mm-hmm.
Um, do you feel like uh, that is something that needs to change about the culture, because of obviously you're a sleep specialist and you just uh, talked about the importance of sleep. Do you think that the culture in healthcare or in medicine is detrimental, or is this something that, like, if you're consistently, like every every day for many many years, not just like the term of like residency for 5 to 7 years or whatever, or do you think that's actually having a negative impact on the people who are supposed to be taking care of others and taking care of the health of others, that's actually negatively impacting their health long term?
Yeah. I mean, we don't need to, we have to have a good night's sleep as as much as we can every
Mm-hmm.
night if possible, right? So I think that a lot of the sleep deprivation is we cause it to ourselves, not necessarily because we work too hard, um, but because we delay our sleep. We don't go to bed until we've watched our favorite show or until we've scrolled through our social media or whatnot. And most of the times that the patients have trouble sleeping is is artificially made, but not necessarily because they work too hard. We can become more efficient in our sleep by changing our habits, creating more structure in our lives. So there's ways to do this. So I don't necessarily feel that, yeah, of course, some people work harder than others, right? But we do see that people with insomnia are not the ones that are not only the ones that work hard. There's also people who can't sleep who are not working as hard or not working at all.
Mm-hmm.
So it's not the amount of work that can be handled during the work hours, and then, you know, structure your sleep or your time around sleep to achieve a 7 hours sleep, 7 to 8 hours of sleep. That is the required
Mm-hmm.
amount of sleep that we have.
Okay, so now I kind of want to go to the biographical side of things and talk about your life before getting into medicine, and talking about your life outside of medicine. So I guess you could talk about your upbringing in Greece, and your time in Hungary, and sort of just you as a human being. Or do you have siblings? Are you
Mm-hmm.
an only child? That sort of thing.
Yeah, so I am a fourth person or fourth generation in my family in the medical profession, as a medical doctor. So I was basically advised not to become a medical doctor
Mm.
by my father because he didn't feel that medicine was, it was just like too rough or too hard, or there were other, not because I'm a woman, but in general, I could go the easier route, but that's what fascinated me from the beginning. So I chose to not listen to my dad and still go into medical school. Um, Overall life in Greece, or where I grew up, was super fun. People are quite relaxed there. Every weekend, I would go do something outdoorsy. Um, I love sailing, so I did quite a bit of that. All my holidays, all my summer holidays were sailing for a month, um, and then hiking and ice climbing on mountains and skiing and things like that. So I had the time, obviously not as a medical student, That was in high school, but as a medical student was very interesting. In Hungary, it was a quite an interesting transition because I went to Budapest about, well, a few years after the wall fell. So the culture back then was shocking to me, because I didn't know anything about, that culture, or or the former communism, etc. So it had changed people so much, and people very nice, but yet at the same time had not seen anyone from a different country before.
Mm.
So they were very suspicious. They grew up being suspicious of people from a different country or people not them. So that was an interesting experience for a teenager or a kid, 17, 18 years old, moving away from the house and my country and living somewhere by myself. So, but these are wonderful experiences that really add to maturity and personal growth. And but the medical school years were rough and tough, so there was not much partying. There's mostly studying, and because Hungary is situated in an area where it has many countries around it, I spent, when I had free time, exploring those countries, such as Slovenia or Austria. I remember I would go on weekends when I had time. We would just go with my friends and spend the weekend there exploring Vienna, or Salzburg. So it was really nice to be in the heart of the Europe and just going around those countries. Um, and yeah, no, these were fun times, obviously, and good memories.
So not so much sailing anymore in San Antonio, probably though, huh?
Actually, I have a funny story. I lived in Boston and I did not do any sailing. First time I did some serious sailing and went to regatta was here in Texas.
Oh wow.
When I moved to San Antonio, we went up to the lake, and it was fun. Lake sailing, but still, I'll
Yeah.
take it.
Yeah, better than nothing. Okay, Dr. Val. So I think we'll wrap it up here, and just as like a final thing, if you were to give a piece of advice to anybody listening, whether they be a medical student or a resident or an attending or just somebody in the community that is listening to you now, what piece of advice would you give them?
So, because you asked me before about what they want to choose in their career path, and I would just say follow your heart. Go to where what draws you, what draws your interest, and you might hear people try to tell you otherwise. Obviously, listen to their advice, but take it with a grain of salt because everyone speaks from their own personality, their own experience, and which may be different from what or who you are and what you want. So if you choose a path because you listen to a few people that were in that path before you and trusted their opinion, that's great. But if you regret it afterwards, or it might not be what really gets you up in the morning, ready to go and conquer that field, then it's not for you. It really has to be personal, coming from the heart, and just like I said, follow your heart.
Very well said. Thank you very much, Dr. Val. I really appreciate you. It's been a real pleasure.
Likewise, thank you so much. Great questions.
Take care, man.
Have a great weekend.
You too.